Good evening, everyone. Welcome to the CSRS Education Society's webinar on technologies in the cervical spine. Our new platform is making surgery safer and more efficient. We'd like to thank all the participants for attending this very informative and interesting webinar. Our speakers tonight will be Dr. Michael McCarthy, Dr. Venu Nimani, and Dr. Shiraz Qureshi. We'll be moderating Dr. Samuel Cho and myself, Dr. Sanjeev Sarotwal. As part of the CSRS, we'd like to encourage you to save the date for our next annual meeting, the 53rd annual meeting and 30th instructional course in Washington, D.C. This year will be held from December 3rd to the 6th at the Westin, Washington, D.C. downtown. We look forward to seeing many of you there. And for those who are not members of the CSRS, we encourage you to apply for membership. Membership applications are open from May 1st to September 15, 2025. And you can look online for further instructions. You can also connect with the CSRS on our social media platforms on LinkedIn, Instagram, X, and Facebook. Tonight's talk will be recorded and be available for future viewing under the webinars section of the CSRS YouTube channel. We also have cadaveric technique videos as well as topical presentations. We encourage you to look up the CSRS YouTube channel for further talks. For tonight's presentation, we will have the three different speakers talk about the various topics here, and we'll have a live discussion at the end, which we find very informative. So without further ado, we'll get started. The first topic today will be Navigation of the Cervical Spine by Dr. Michael McCarthy, MD, MPH. He is assistant professor at Indiana University and part of the Indiana Spine Group. Go ahead, Dr. McCarthy.
Thank you, Sanjeev. I appreciate it. So I'm Mike McCarthy, and so I'm really excited to kick this off. I think this is a really cool webinar, and so we'll be starting off with navigation in the cervical spine. So here are my disclosures. We'll be talking about a variety of different navigation platforms tonight, so I don't think any of these disclosures have any significant bearings on the talk. But I'm kind of a big believer in navigation, and probably the biggest disclosure that I have to give is just the regional trend of navigation and where I work. There's more O-arms, I feel like, in the state of Indiana than there are anywhere else in the country. But I think that the utilization of that is really very clearly evident when you use navigation, whether that's the placement of screws, the reduction in radiation, that real-time feedback and confirmation of placement, that streamlining and taking some of that decision fatigue that we all feel in the OR kind of out of the equation. And then let alone some of the complex anatomy situations when you're really trying to worry about fixation and how do you really kind of accurately and efficiently place screws. Something I think is really important, especially for the younger surgeons, is what navigation can kind of give to you as a tool. I think when you get out in practice, you're trying to match partners who are 20, almost sometimes even 30 years into practice, and there's an experience quotient that's really difficult to achieve. And I think navigation can really help out some of those younger surgeons as they navigate some of the early issues of practice, especially with placing instrumentation. So what is navigation? Well, this was really adopted from a lot of intracranial uses, and this was a Sentinel paper by Nolte in 1995, where he talked about that transition of navigation from intracranial applications to the spine. And just for those folks in the audience who don't really use a lot of navigation, aren't very well versed with it, you can see some of the basic points or parts of of navigation here. You can see on the far left the dynamic reference array. The next picture on the right is image acquisition system, and again, there's multiple systems. There's your optic camera that captures the instruments, which you can see on the far right with the fiduciaries, and then correlate that with the reference array. So for those of us in the audience who are pretty well versed with navigation, this is just a smattering of my cases. It goes all the way from MIS T-lifts, which on the far left, to my open cases on the far right, where I think navigation has a role and again, I think can be really, really helpful. But what about in the cervical spine? Does that, maybe that comfort you have in the thoracolumbar spine using nav, does that readily transfer in the cervical spine? And I think so, and I think it really shines a lot in a variety of different applications, but even more so specifically in those complex anatomy situations, really when we think about the OC to C2 kind of region of the upper cervical spine. Think of that aberrant V3 segment. You think those small lateral masses. You think the pedicles, high riding vertebral arteries, all those things that make that allow navigation to shine, but make fixation of the cervical spine difficult. I know in Indiana, you can see that far right-hand corner. Some of our patients, it can be difficult to really obtain good APM lateral fluoroscopy. So just getting a good shot to try to get a cervical pedicle in can be tough, and navigation can help mitigate some of those issues. Less dissection, I think, is another added benefit. I don't have to see everything. I don't have to see every ounce of anatomy to accurately place screws. I can save some of that incision and decrease in the overall morbidity. And then I think again that immediate confirmation that what the tactile feel I'm getting when I'm placing screws, I'm also visually confirming that based on navigation. But what are the downfalls? What's the pitfall? Why is it not readily transferable from the thoracolumbar spine into the cervical? The biggest issue we see in the cervical spine is the mobility of each individual vertebral unit. And we have to think that, oh man, if I lock the neck down via Mayfield, I'm going to be good. And that's not necessarily the case, right? There's a lot of play that can happen in the system that can make navigation inaccurate and start to add in errors. You don't have a lot of real estate, and so you have to really think about where you're placing this. And then once your self-retaining retractors are in, that those don't move. You got to really lock it in and then get the spin and get to work fairly quickly. Additionally, navigated instruments, you're doing some midline. You're crossing the midline with these at times, and so there can be collisions with the dynamic reference array. Again, proper planning, I think, can help mitigate these, but these are some of the issues when you really think about its application in the cervical spine. I'm not going to get into too much regarding the actual different platforms because I don't think that's very helpful because most of us in our hospital systems probably have these, but you can see they're ubiquitous across the country and there's a lot of them. So what does the literature say about nav? I think this is pretty clear. These three things tend to shine when you look into safety, when you compare free-handed screws versus navigated screws. I think we all know that the accuracy, the less medial breaches can be clearly seen. The efficiency can help. I think it can actually speed you up in the OR when you learn how to use it. But even more so from an efficiency standpoint, I think it can very much allow you to create more robust construct. You're using larger screws, bigger screws, better purchase. And really the hope is that translates into better fusion rates. But the thing I really hang my hat on when it comes to navigation is very much with the reduction in radiation exposure. And that's radiation to us, to our patients, and to our team. And when you think about the low dose pulse sequences and the amount of millisieverts that we're receiving, it really has a significant impact, and I think the overall radiation exposure throughout our career. So as I think about the advantages, as I alluded to, the radiation exposure, but also just the basics of cervical spine, the pedicle screws. This has a great application in tumors, really wonderful when you have high riding vertebral arteries. You think about the workflow. This is an odontoid screw, and that's what it looks like in my OR when I do bivector C-arms, and it's a busy, really kind of an ugly OR to work in. It's just a lot of stuff. When you can see on the far right, this is what it looks like when you're using navigation. This is me and my fellow. We're working. We have a clear field. We don't have a lot of hardware in and out of the field or blocking our views. A point that I really believe in when it comes to navigation is the teaching component of it. And a lot of people have mixed emotions, but I think there's no better teaching instrument than real-time feedback. And when you have someone placing a free-handed screws and you can say, stop and tell me where you think you are, and they can look at a screen and get that, it really is a wonderful education platform. As I mentioned too, optimizing screw size and trajectory is really an added benefit. But why don't more people use this, right? And I think the biggest issue that people tend to tell me is that it takes too long. It's too much effort to get this. That it's like the Apollo missions trying to get the lunar module landed, right? And I think really that relies on you as the surgeon. You are the leader. And these are the three folks that I rely on for all my navigated cases, my tech on the far left, my industry representative up on the upper right-hand corner, and my CST in the bottom right-hand corner. They know when we need the O-arm, they know when we need to get everything ready and registered as far as instruments. And it's not a giant feat to get this going, let alone actually getting the image. People tell me all the time, man, okay, well, if I even have the workflow, getting the image acquisition system in and out of the OR, it takes too long. It's going to take me 15 or 20 minutes. And I tend not to buy that argument. This is just a case I did last Tuesday. You can see it takes 3 minutes and 51 seconds for that Patient gets sterilely draped for the image acquisition to close, spin, and then the drapes are off and we're off to instrumenting. So I think really, again, it comes down to the surgeon to be a good leader and to organize their team to utilize this technology. So once you have your spin, what does this look like? So this is a standard setup in my OR. You can see I typically have the self-retaining retractors away from the dynamic reference array, which is typically transfixed to the spinous process, either C3 or C2, depending on what type of case we're doing. But you can see there's a tap on the far left, and on the right, you can see there's a pointer that I'm able to kind of get a good understanding as far as what the anatomy may be. An alternative setup would be an extension off the Mayfield. This is a patient that had already had a previous posterior fusion and needed a revision, so we didn't have much bony fixation. So you can see this is my fellow putting that outrigger device, and on the far right, you can see what that looks like in the OR. Again, another very helpful way to use navigation. Here is the actual workflow. This is placing screws. You can see the tap that's getting placed, and we can advance it. We can size it. That yellow bar is typically my rep showing you the size, whether that's a 3.5, a 4.5, a 5.5 screw. What's the length? Whether it's a 30, 35, or 40 millimeter. So again, exceedingly helpful to real time see that. I thought I'd go through some case examples to give you a better example of where I think NAV shines. So this is one of my patients, a 77-year-old female with right-sided severe occipital cervical pain, pretty classic C1-2 arthritis. She went under kind of a fairly extensive non-operative care, and you can see what her sagittal and coronal images show is just that osseous erosion of the C1-2 joint and how diminutive that C1 lateral mass can be. And again, freehanding that can be a tough day in the OR. So you can see that when you use nav, I clamp on the back of C2, and in the upper right-hand corner, you can see this is real-time placing that C1 screw, and then I can upsize it. I can get all the way up to the front cortex. If I want to go ahead and get bicortical, that's not too big of an issue for me to do. I don't really think twice about it, or I fret and have to take a million different x-rays to see where I am. This lady had a high-riding vertebral artery, so again, I audibled fairly quickly to translaminar screws. You can see how long those are. And just the length of that fixation, the rigidity of really filling that laminar part of it. This is another case, again, just able to pull audibles in the OR because you have this real-time visualization of the anatomy. Again, another fairly diminutive C1 lateral mass. I had to place the screw a little bit lower to achieve maximal fixation. I don't know if I would have really done that. If I was under C-arm, I would have probably tried to match the other screw. And again, you can see I did a little mix match of a translaminar and then a C2 pedicle. Just based on her anatomy, I thought that was really the best application of the fixation. Here's a second case I think that, again, really highlights it. This is a 58-year-old gentleman who had a history of a nephrectomy and unfortunately showed up to my clinic with worsening neck pain and had a biopsy-proven renal cell carcinoma, solitary metastasis. And you can see just that osseous erosion that's occurring and thinking about what we're going to need to do to resect this and to treat him. And so here's the MRI cuts, just again showing, man, this goes out really lateral. And unfortunately, as you look through some of these axial views, you'll see that tumor is very much involved in the vertebral artery. And so you got to do a lot of thinking of how am I going to address this? And so preoperatively, we embolized the tumor, but I knew I was going to use NAV, so I asked them to go ahead and place a metal stent through the vertebral artery, not only protect it, but also allow me to work in and around it with my navigated tools. And you can see the spot shot that on the far left, just with the setup. You can see what it looks like when I have the clamp on, and this is before the spin and what we're able to do just from an image acquisition standpoint. And then this is the actual case. You can see this is a close-up of placing those T1 and C7 pedicles, and those are 5.5 25s in C7 and 5.5 30-inch screws or millimeter screws at T1. So again, exceedingly robust fixation because I knew I had to remove a fairly extensive area and I wouldn't have lateral mass fixation on the right. And so I can really, again, use NAV to leverage the type of fixation that I'm achieving and really place exceedingly large screws in there. And again, once those were placed, I needed to move on to resecting the tumor. And again, just from a negative perspective, you can see the C6 nerve root, C5 nerve root that was really getting pushed ventrally. And then I used the pointer to resect. I could see in and around the tumor. I can see how far out laterally I need to be. I can see where the vertebral artery is, and then use the sonopet to really remove as much of the tumor as possible. And you can see this is kind of after the resection, how much I was able to get just from a posterior approach. And then I was able to take them anteriorly and do a corpectomy. Another big added uh, benefit of the 3D rendering, I can get a good sense after everything is played, view of what I've achieved from a fixation standpoint and also a tumor resection. And again, here just the finals again showing the corpectomy. So in conclusion, I think this is very much a tool that can make your life easier as a surgeon. But like any technology, we have to remember it's just a tool, right? It doesn't really drive what we do. It just helps us get to that destination. Those basic tenets of why that patient's in our office, the stenosis, the instability, the deformity, those are the key things we have to focus on. And that decompression, stabilization, optimizing alignment are only kind of, we're able to get to those successful outcomes with utilization of NAV. And so again, I think much like a lot of new technologies we're going to talk about tonight, I hope that you can see the application of NAV and its benefit and utilize it. I do have one last slide. This is mostly for our New York audience, and go Pacers.
And I'd like to thank all three speakers for their outstanding talks on emerging technologies in the cervical spine. Now the session is open for Q&A. If you have any questions, please type it in the chat box and we'll try to address some of them. And by way of starting, I'm going to ask all three speakers on the topic that they actually had covered, and that is the mobility of the cervical spine. The number one question is, how do you stabilize the cervical spine when you're positioning it? And number two, intra-op, I think Dr. Numani had mentioned he likes to use the burr instead of pushing on the cervical spine to because of the mobility issue. How do you deal with that? So how do you immobilize the cervical spine? You use
Sam, I could start there. It's a
yeah.
what so specific to me, and I'm sure Mike and Venu and others have their own ways, but I instead of using a Mayfield or Gardner Wells tongs, I'll use a face positioner, similar to what you might think of somebody, a face holder that you might use in the cervical, in when you're doing a lumbar case. I do find that that results in even more stability of the cervical segment than a Mayfield does. And then I am pretty liberal, even if I'm working with navigation or through a robotic arm with the use of fluoroscopy. I think it's a great place where you want to sort of use everything in your armamentarium as far as imaging goes to ensure that you have accuracy. And I haven't yet done robotically placed percutaneous pedicles, screw fixation in the cervical spine. Waiting to take the leap on that one, but at least in an open case, I'll still have the C-arm sort of draped in, and then have the face and the neck in a face holder, tape on the head, so that you get as much stability as possible. But even with that, there can be movement. What I find is that setting the trajectory and the starting point sometimes can be of greatest benefit, and then just kind of staying within those angles. But it's something that you need to be cognizant of the entire time.
Yeah, so I also do something similar. I don't use the face pillow, which is a good idea, but I also use a Mayfield. I think for some of the technologies where you have to register to an intraoperative CT scan and then you rely on the frame not moving the entire case, I think it's super important. One of the potential benefits from some of the other technologies that I talked about is there's less of that reliance on not bumping the frame or movement because you can just re-register very, very quickly. I think also with 3D printed guides, for example, again, because they're segmentally based and they sit on the posterior elements of a single vertebrae, then there is no chance for shifting. However, one unique thing that can be an issue there is if you position the spine in lordosis, or meaning an extension like you might in a Mayfield, if you want to just set the alignment before you start, the guide can actually have interference from the adjacent facet joints because they're shingled, or even the adjacent spinous processes. Because the design of the guide is based on their position in a CT scanner, and sometimes you might have the head, with a bump behind it or something like that. So you have to be mindful of that. So there are some nuances from a positioning standpoint that can play a role in this. If I'm using 3D printed guides, I actually usually position the spine in Gardner-Wells tongs in flexion. That way there's less interference from the adjacent anatomy, and then I'll just use bivector traction and then place the spine into extension when I'm dropping my rods and locking in the final alignment.
The way I tend to think about it, Sam, is once that spin occurs, an intraoperative spin, it's kind of like a nuclear isotope. It's going to decay. How rapidly that decay is happening, it's difficult, but I think especially in the cervical spine, you have to be acutely aware of that. So I tend to think that as soon as I capture that, that's the most perfect information I'm going to have. It's all going to slowly become more and more inaccurate. So I will wherever I've clamped with, that's again typically C3 or C2, I then go and do my furthest segment away. So if I'm going to instrument T1 or do any cervical pedicle screws, I go furthest away and then work my way back up towards the reference array. Again, always thinking of time and distance as the enemy. So time from spin and then distance from array, right? Those are two things I always kind of beat into the fellow's head, is those are their enemies.
Thank you. Those are very useful answers and very helpful tips as well. Dr. Wilmer from Godoy thanks us for the excellent talk. And there's a question about changing alignment during the case to provide better lordosis. So anyone want to?
Yeah, I could start there. I'm sure I use an old trick that I'll place a IV pressure bag under that same face pillow, and then right before, after all the instrumentation is in, I'll have somebody squeeze the bag, which allows, sort of this improvement or restoration of lordosis. Take an X-ray, see what that looks like, and then place the rods.
Yeah, I use so in a flexible spine, I think that placing the placing the patient's head where you want it, getting an X-ray and making sure you're happy with it, I think works well. For some of the more severe deformities, I will often use Gardner-Wells tongs, or if you have it, a pneumatic Mayfield, where you actually have control of the head through the drapes, and then you can adjust the head position intraoperatively, although realistically, sometimes it's a little hard unless you have the drape that comes with it. It's hard to grab the handles and actually adjust it. So I'll often have an assistant or one of our PAs or even a resident or fellow get under the table and manually manipulate the Mayfield and the patient's head while you bring the head up with the pneumatic head holder. And so there are some tricks there. The other things that you can do is intraoperatively, if the posterior elements are still intact or the spinous processes are still intact, you can use Atlas cables around the spinous processes. And as you tighten the Atlas cable, that will bring the spinous processes closer together. You can also use a penetrating towel clamp to essentially squeeze on the posterior element, and that because it's a fair bit posterior from the center of rotation of that individual vertebral segment, that can also generate lordosis as you then tighten your set screws and lock down your rods segment by segment.
Great. Thank you very much. I think it's already 9:01, so this will bring us to the close of this webinar. So this will be uploaded in YouTube. So join the YouTube channel for CSRS, and then look out for the next webinar. Thank you, everyone.